volume. Can you hear me now?
We can.
Okay, all right. Okay, so I'll start. I'm going to talk about an interesting case I came across at St. George's Hospital, and I'll just dig into it straight, and so that we'll have more time to discuss the case subsequently. So to start with, this was a 26 weeks plus 2 day gestation baby born with birth weight of 900 grams. This baby was born at one of our tertiary neonatal center, not at St. George's Hospital. This is a tertiary neonatal medical center that we provide surgical care to. This baby was born by spontaneous vaginal delivery, and little one received an incomplete course of steroids. So received 1 dose of steroids, I think 6 hours prior to birth. This baby was born in good clinical condition and received less invasive surfactant at around 2 hours of life, and was established on high flow in around 24% oxygen by around 8 hours of life. He actually progressed quite well for first 24 to 36 hours and had a routine abdominal X-ray because of slightly distended abdomen. And the X-ray demonstrated pneumoperitoneum. So that was an X-ray seen on the left side. This was the X-ray done in local hospital, where this baby then was intubated and ventilated to facilitate transfer to surgical center. The abdominal X-ray, as you could see, demonstrates the falciform ligament and a football sign. This little one did not have central line at the time, so it was transferred to us with 2 peripheral cannulas. This baby, after coming to the unit, was optimized, had a UAC and UVC cited. The UVC was suboptimal, as you could see here, with a bit of air in the portal tract. This baby also had a drain put in because respiration was getting difficult, and baby then subsequently went to theater. In the operation time itself was quite uncomplicated. They observed that there was a distal ileal perforation, was around 5 centimeters from ileocecal valve, and there was a minimal contamination of the peritoneum. So had a stoma formation, and baby then came back to the neonatal unit. Baby received around 30 ml per kilo of volume and was on dopamine at the time. Small dose, 5 micrograms per kilogram per minute. Because the UVC was suboptimal, a long line was inserted and the UVC was removed. And this was an X-ray following a long line insertion. This line was inserted in a right antecubital fossa, and the line followed an unusual course where it went into neck, and we don't have a full X-ray, but it looks like it had gone and coiled back within the neck, and hence the POCUS was requested. So the aims for POCUS, or questions for POCUS, were 2. One was this an arterial cannulation, because there was a lot of oozing noted at the site of insertion. And the second question was, can we adjust the line under ultrasound guidance to get it in optimal place so that we can use it? Sorry, can you all hear me clearly?
You can do a bit better, Anay, if possible. We can hear you,
yeah.
But your voice can, the audio can get better if, is there any settings you can do? I can see Sandeep is there to help you out. If you see.
We can hear you okay, Anay.
Okay.
Okay.
Right. So
Shall we go on then?
Carry on, because I think if I were to do anything, this is quite fragile computer.
Okay, go on. Just come closer
to
the your.
Fine. Yeah. So building on what we discussed, there were 2 questions. One was, is this into an artery and gone into right common carotid artery, or whether it's a venous? And second question is, can we adjust this line? So I'm just going to show you a few POCUS images. So first question was, is this line in an arterial tree, or it's in a venous structure? So if you look on the left side picture, you can see that this is a line which is in a vessel, and there are 2 vessels which are running parallel to each other. So there's one vessel here and there's one vessel underneath. By rule, your venous structure are superficially when you're scanning them anteriorly, but that was confirmed by this Doppler placement. As you could see, as soon as I put a Doppler gauge, you can see a pulsatile flow in a vessel which is lower down, and you can see that line, which is in a vessel above it, which confirms that this was within a venous tree. So I changed my probe from multi-phase array to curvilinear probe to try and define the line course. And this was again a chest ultrasound. I was just within right infraclavicle region, and this is a subclavian artery, a subclavian vein, apologies. And you can see a line within a subclavian vein. There is a subclavian artery just underneath this subclavian vein, and this line was going in. I could not define a course from here on. So now this is a slightly unusual view just to give an orientation. This is a coronal section. This end is a head end. So the left side is head end and the right side is leg end. And actually you could see that this line was in IJV, which was going into a subclavian vein. So this is the tip end, the distal end of the line, and this was the proximal end of line, which demonstrates that it goes into IJV, and then this is a subclavian origin. So the same line, now we are pulling that line back just to give an orientation. This is the same picture as before. This is a subclavian artery, and that's a subclavian vein, which is joining IJV. So the line at the moment is junction of your IJV and subclavian vein. And this is the final position of the line, where you can see the line tip within a subclavian vein, and this is your internal jugular vein. So it was at the junction of two vessels. So this line was going in IJV, coiling back, which we pulled back with tip being in here. So my conclusion at that time was this line appeared to be in optimal place, probably at the junction of subclavian vein and IJV. Now this couple of slides about the probe. So obviously apart from doing a head ultrasound scan, I was trained for echocardiography, and you always have a very favorite probe. So my probe has always been a multi-phase array probe, which I've been trained to do echocardiography for a long period of time, but we just have to be aware that all the probes have their pros and cons. So for example, the multi-phase array probe that we use for echocardiography, all the sound crystals are actually grouped together in the center, and they are phased out in a phased manner. They start from single point and fan out, and obviously this probe has a smaller footprint, so you can use it and fit it in the space where you don't have much of acoustic window, and you can image in smaller space. But the problem is you lose the lateralization when you use this probe, because if you are looking at the structures which are lateral, you would not be perpendicular to those structures, and your imaging would be suboptimal. As against if you look at the curvilinear probe, which is a standard probe which you use for head scan, you have a curvilinear surface, and all the crystals are aligned along the curved surface, and it just gives you a wide field of view. Typically, they are low frequency probes, so you can get better penetration, and then you can scan deeper structures. But obviously, you can use this probe when there is no limitation of space. And actually, I find it very helpful in scanning these babies where the lines are slightly peripheral. They're not in the SVC or IVC, where now both the imaging is at the same location for the same line for the same patient by the same operator. But as you could see, if you use a multi-phased array probe, you can see the line, but you really lose out the orientation of the supporting structures. As against here, with a curvilinear probe, you can see it much more clearly. You can see where the line has come from, you can see where the line is going, and it just gives you better definition. So, it might be a good idea to use both the probes to try and define the lines, especially the head and neck lines where the anatomy is slightly complex, and you may need to have an orientation of structures surrounding. So this baby, then we continued using the PN, and we did not do an X-ray post-adjustment because the line appeared to be optimal. And baby progressed quite well. On day 6 of life, this baby who was minimally ventilated got worse from respiratory point of view. The oxygen requirement, which was in high 20s, went as high as 60%. Also had an acidotic pH with high CO2. The team rightly so did a cold light, suspecting to be a pneumothorax as explanation for acute respiratory worsening, and was changed to pressure control mode from volume. And the team were awaiting an chest X-ray when I was asked to do a POCUS, or point of care ultrasound scan. And this is what the scan demonstrated. So this is a lung ultrasound scan, essentially using curvilinear probe, where you can see a significant pleural effusion and the collapsed right lung. There's a lot of speckly echogenicity within the pleural fluid seen on both the sides, suggesting that this was probably a PN leak. At the time when the pleural effusion was diagnosed, the line still appeared to be in a major vessel, which you can see here. This is a subclavian vein, and that's your IGV. So it actually remained at the same location where it appeared on the first ultrasound scan. So essentially, this baby then had a chest drain put on right side, which we drained around 50 mils of lipid and PN, and baby got better and was extubated by day 11 of life. So essentially, to sum up a 26-weeker who had a surgical abdomen, who had a laparotomy, who had a long line placed, which was adjusted under a POCUS, and was felt to be optimal, was used for PN, subsequently developed a PN extravasation leading to pleural effusion, needing a drainage of PN from the thoracic cavity. And then comes to a question, really, did this ultrasound, the scan that what we did, caused harm? And I'm being very open and straightforward. I mean, I do believe that ultrasound should be the way forward for lines, but still we should ask these difficult questions. Did this ultrasound did not diagnose the tip correctly? That was one question. And second question is, had we not done an ultrasound and done a chest X-ray, which is what the standard practice in a lot of units, would that have prevented extravasation? And we'll try and answer those questions in subsequent slides. But before we go that, I would just like to bring this back to this BAPM best practice guideline, which was published in 2018. This is, I think, Neem laid on this particular document, which is lovely document talks about the framework that we as a clinicians to use central venous lines safely. And I would just like to get you to the point 16, where there is emphasis on using X-ray to define the long line position. So this particular 16 point says that there should be a thorough continuous documentation of each central line and defining position on the X-ray and any adjustments subsequently made. And the accepted position should be verified in writing within 24 hours of insertion by a neonatologist or a pediatric radiologist. Now, a lot of recommendations that you could see in these guidelines, they have this asterisk, which just means that they are based on consensus opinion or expert opinion. But that's what a best practice framework suggests, that how we should define the line. And I mean, luckily, this baby actually did quite well, and there wasn't a significant harm caused. But if had there been a significant harm, I think it would have been difficult to defend using just an ultrasound to define the line position. This was some work which we did at St. George's. We reviewed our lines, around 500 lines over 3 years period. This was from 2019 till 22. And we use an objective definition of optimal line placement as suggested in the BAPM document. And we demonstrated that if your line is suboptimally placed, it's significantly associated with increased complications. So it's 1.7 times more likely to be associated with complications. So if your argument is that POCUS actually falsely allowed us to use a suboptimal place, that we know that is known to be associated with complications. And I think I've done over 250 POCUS lines at this unit, and I've been collecting prosperity data in terms of harm because of POCUS. So I'm just putting it there. Actually, it's quite safe investigation of around over 200 assessments. I think 4 patients, the lines were still observed to be in cardiac sellout. Now, these X-rays were not done on the same day. They were done subsequently for different indications. And there were 2 lines which were felt to be optimally placed on POCUS, were observed to be suboptimal on subsequent X-rays. Now, one could argue that X-rays can do that. So if you were to decide or define the line position just based on X-ray, we know that those lines move. So I don't think this is more than what you would observe if you use X-ray as a marker for line definition. In 3 babies that we scanned, we found some additional things, and that needed additional echocardiography assessments and follow-up assessments. They were all trivial, but one could argue that because of doing a POCUS, you observed something which was not questioned, and that led to subsequent assessment and maybe potential some anxiety around the findings. So coming back to this first X-ray, first ultrasound. So this was a line placement, which I observed on the first, when the line was inserted, and actually on ultrasound, it looked to be optimally placed. On ultrasound, I feared that this line was at the junction of subclavian vein and IJV. And after this baby developed pleural effusion, we did an X-ray. And that was the line X-ray. And actually, if you look at anatomically, just purely from X-ray point of view, it is exactly at the same location where ultrasound suggested. Following this event, I sat down with pediatric radiologist who was in agreement in terms of location on first POCUS, which corroborated well with the X-ray, as you could see on the right-hand side. It also showed that there was a pleural effusion, which we saw on ultrasound, and there was a bit of pleural effusion on the left-hand side as well. So to conclude, so there were two questions to start with. Was the tip not correctly identified? The X-ray that we did subsequently demonstrated that actually tip was correctly identified and actually was at the place where we thought on ultrasound. And the second question was, had we not done an ultrasound on the first occasion, instead we have done a chest X-ray, would that have prevented extravasation? And the answer would be no, because the chest X-ray would have still demonstrated that the line was in acceptable position and would have been used. So I would just spend next couple of slides just talking about pleural effusion associated with a central line. Now this is an old data from Canada, the first line. The incidence is around 0.4 per 1,000 catheter days. Now this was, I think there were multiple units from Canada were involved in identified actually the true incidence. We know that the bilateral pleural effusion, because of PN extravasation, is quite rare with central line. The median time from catheter insertion development can be up to 2 weeks. It can be, but the range being 7 to 75 days. So it can happen very early, but it can happen as late as 10 weeks from the time of insertion into the insertion of a line. There are several factors associated that are described in the literature associated with pleural effusion with PICC line insertion. The risk factors being premature babies with surgical abdomen. The hypothesis how surgical abdomen can make a baby prone for PN extravasation is that this babies who have undergone laparotomy can develop prothrombotic stage post-surgery, which may make them vulnerable for having small thrombi and clot formation leading to pleural effusion. Again, these numbers are very small when I'm putting them there, but the upper limb is more likely to be associated than lower limb with PN extravasation. And the reasons for that is you see more movement of the line with upper limbs as compared to the lower limb, and the upper limb venous anatomy is much more complex as compared to the lower limb. So in either lower limbs, if you put line, it still goes into one vessel, as against for the upper limb lines, they can go in 3 or 4 different vessels and still be used. Obviously, if you are suboptimally placed line, that is known to be associated with pleural effusion or line extravasation with PICC. So this is our local data. We looked in how frequently do we see at in our own institute. So we're based in Southwest London. We are around 5,000 high-risk deliveries. We are one of the 5 fetal therapy centers. We look after around 150 babies less than 32 weeks gestation and around 80 babies, almost half of them less than 28 weeks. We are a surgical center. So in the last 14 years, we've seen 2 extravasations in this center. One was at 28 weeks gestation. This was an abdominal PN leak following a UVC insertion. I think Mahmoud shared an interesting case following umbilical line extravasation into peritoneum. And this was the second case, which was 26 weeks with PN leak in the chest, which makes the incidence in our local unit as 0.06 per 1,000 long line days. We roughly have around 2,500 long line days every year in our unit. And there are a lot of potential mechanisms that are described in the literature. The first mechanism being vessel perforation. Now, thankfully, this is quite rare in neonatal population because we don't tend to use a lot of guide wires. So these are described more so in units where they are PICC and IC together, where they've used guide wires. And usually they present within first couple of hours or within few hours post insertion of line, leading to a vessel perforation leading to hemothorax and significant hemodynamic compromise. There is an interesting description about retrograde flow of passage through a lymphatic duct. Now, this is identified on post-mortem examination, where essentially a line was put in upper limb, and the line tip ended up within a cisterna chyli, leading to PN distribution through thoracic duct leaking into the pleural space. Typically, if you get a leak, that would be the mechanism. Typically, if you have a leak which is bilateral, or if you have a bilateral pleural effusion, that would be a potential mechanism. Now, mechanical vein erosion and hyperosmotic injury to the endothelium, I think this is probably a mechanism that we saw in our baby. We know that the PN that we use has an osmolality of around 1400 to 1500 milliosmoles. At least that's the osmolality of the PN that we use in our unit. If you see serum osmolality of 280, then that's quite hyperosmolar solution. And the hypothesis here is that leads to necrosis of subendothelial tissue, leading to leak of PN into the pleural cavity. Catheter tube in subendothelial area, again, is quite possible, but again, can only be unfortunately diagnosed on PM. It's quite difficult to diagnose them clinically. Thrombosis of pulmonary vessels is again described in a post-operative patient who was volume depleted and was prothrombotic, and a line actually migrated through right ventricle into the pulmonary arteries, leading to leak of fluid within the pleural space. I think the commonest mechanism described is this, where if you're using a hyperosmotic solution, that can lead to injury to the endothelium, leading to the PN leak in the pleural space. And one would then ask, which are the sites which are better avoided? Now, the literature is quite divided on what are the best places, or what are the worst places rather, where you should not leave your long line tip. And a lot of this data is adult data. There isn't any neonatal data to talk. One of them is actually post-mortem examination. So if you look at this old paper from 1992, this is from adult ITU. They claim that this location, where actually your innominate vein drains into right brachiocephalic vein, is the most vulnerable part. And the rationale they've given is your innominate vein inserts at angle in your right brachiocephalic vein, and that angle leads to increased pressure flow, leading to a necrosis of the subendothelium, leading to the leak. There are some post-mortem studies which actually talks that your medial wall of SVC is much more weaker as compared to your lateral wall of your SVC. I mean, clinical relevance of that is not much in my opinion, because it's quite difficult to control where the line goes, but that's been described as one of the places where you should avoid line placement. Now, this controversy continues into the adult world. This is a nice review paper from published in British Journal of Anesthesiology from 2000, where actually they have identified 3 optimal places where you should leave lines. The lines used in adults are obviously different to ours, but the 3 safe zones, as they've described, are zone A, B, and C, where zone A is at the junction of RA and right superior vena cava. Zone B is just proximal but distal to junction, and zone C is within an innominate vein, but not close to the junction, especially for the left-sided necklines. Now, coming to, in terms of, this is one more slide, what are the different ways that you can use to try and define the line best? So you can use contrast, but there is good data to suggest that contrast on the X-ray may over or underestimate long line position and tip. There's an interesting work in adults where they've used intravascular ECG. Actually, one of my colleagues who I worked with did a fantastic work in Canada looking at a metallic ECG trace to see whether you are in right atrium or not. Suddenly your P wave starts going up. The problem with this, it's a practicality, because we know that any metal can generate a static charge, and you probably would not want any static charge within your right atrium. So there's a theoretical risk of burn, which you wouldn't want to do. Obviously, POCUS is upcoming and evolving and actually very promising. There's good data to suggest that repeated X-rays in these babies do not prevent these complications. So I think this is my last conclusion slide. I thought I'll spend more time discussing, seeing what everyone's experience is. I think the pleural effusion or PN leak, it can happen in an optimally placed line, which is what we saw in this particular case. It is very, very rare. So in this unit, twice in the last 14 years. And if you have a baby who's born prematurely, if they have surgical pathology and upper limb, they are the high risk factors that are associated with PN hydrothorax. One should use all the probes, definitely curvilinear as well as multifid as arrest probes to define the line, especially in head and neck vessels. And we don't really need a BAPM framework recognizing use of POCUS. This is, I won't say defensive practice, but this is just from governance side of things. It'd be nice it to be recognized, hopefully, which we will do moving forward, that a POCUS can be a good, reliable tool to define the line position. And I would like to stop there. Be happy to take questions or comments, or if anyone would like to share experience, be more than happy to listen to.
Thank you. Thank you so much, Anay, for such a wonderful presentation. And I'm sure there will be lots of questions. But before I open it to the floor, is it okay if I have a few questions to you, Anay, just to clarify?
Yeah.
If you can take me to your slide, Anay, where there was the slide on day 1 when the baby came in, had a UVC as well as central line. So where you had a UVC inserted.
Let me go back there. Yeah, go on.
You had a UVC, UAC both there.
Yeah.
No, so next one, not this one, the one after that.
Yeah.
So what we can see is UVC. This is the UVC, right? And then you have got UVC on the top.
Yeah.
So the UVC doesn't look that bad over here. So did you do POCUS on the UVC?
Yeah, I have done POCUS. I can show you the image. Actually, these are one of those difficult midline UVCs where the perception is that they're okay. But actually, on the ultrasound, this was within a portal sinus. I've not shared that image.
I understand that.
So we looked at that. So there was no need to actually put a central line in a good place, but it was suboptimally placed actually.
All right. No, thank you, Anay. And the second question, Anay, was that you're in the POCUS, which you demonstrated beautifully. How do you maintain your aseptic, field? Why inserting long line in a 600-gram baby, which can't be difficult, right? With the curvilinear probe there. And this is what, so can you take us through your steps? How do you maintain that aseptic?
So it was difficult. I mean, luckily this baby was 900 grams, so slightly bigger. And essentially, we did use a plastic sterile cover to be able to see. We needed 4 people to be there, one to secure the airway. There was one operator who was pulling it under ultrasound guidance, and there was just another staff member watching, making sure, because as you scan these babies, you get quite task focused. So it wasn't easy, but you could do it. I mean, the whole assessment did not take more than 8 minutes, 5 to 8 minutes.
And do you scrub yourself when you're doing this? I know you use the
no, I did not scrub myself. So I used sterile gloves with sterile cover, but that wasn't in sterile field.
Okay. And third question is, Anay, for us, my practice has usually been to leave, and I know you showed zone A, B, C, but my practice usually, particularly in preterm babies, is to leave the long line tip at the SVC RA junction close to the thebation valve, which you defined as zone A. And probably your line here was more in level of, it's a great vessel, and in most of the PICO and adult, it will be acceptable. But it was more at the junction of your, as you mentioned, internal jugular and subclavian vein. Is that something you, in your practice, you accept at St. George's? Because we are a bit skeptical about that position in our unit.
So I think at George's, we accept all central veins placement. So subclavian, innominate, and IVC, I would accept. I mean, if you look, the literature is quite divided in terms of so I think going forward, first thing is, I think defining line at the junction of SVC and RA itself is not very straightforward, as you know, because the babies with poor windows, you may not get that straight line. Subcostal views are very suboptimal to try and see whether the line is in RA or not. And actually for the left-sided line, my practice is always to bring it back and leave the tip mid-innominate vein. So at the place here, which is actually quite convenient because you can you have a kind of a luxury of having this horizontal. Sorry, let me just go to that spot. Yeah, so I bring it on the left side, I bring it and leave it there, which is what this zone C is, which is not actually at the tip, but it's in the middle. So you're not actually sending a jet across at one point, but you see a good length of line. Obviously, if you have a line which is far too in, pulling it back is easy. But if you have line, as I showed, which is actually not followed the path, I would accept if it's in right subclavian vein.
No, thank you, Anay, so much.
And if you look at lots of PSU adult data, the central lines, as in subclavian lines, are accepted as a reasonable assessment.
Yeah, I know in PICC settings, because I think the blood vessels are bigger in size and thicker endothelium, they accept any grade vessels. But in liquid settings, we generally, particularly in extreme preterm, we generally go for very close to the insertion of the grid vessels at the heart.
I think the issue here is if you are miscalculated on ultrasound, and if the tip is, and if there's a redundant length of catheter within the RA, you know that is itself associated with the risk of tamponade. There's lots of good tamponade data or studies, and not case series where actually this has been identified as a risk factor. So you really need to be very, very accurate.
Absolutely.
For you to be at the junction B. And actually, personally, it is quite difficult to be absolute at spot on at that level.
No, I completely agree. And this again brings us to the point that we deal with really tiny, very low gestational age babies. So the margin of errors and the margins of wounds are so tiny. So a little bit of movements here and there can be a problem. So we have lots of questions over here. I cannot see who has done first or second, but I'll put it with no preference. I will go for Mohammed Bhari first. Over to you, Mohammed.
Hi guys, can you hear me?
We can hear you very crisp and clear.
Excellent. Thanks, Anay. It's very, very interesting case, and the X-ray with air in the abdomen is quite impressive. It's not actually a question, but sometimes we use this tip while trying to identify the tip of any long line while you're doing the ultrasound. You can flush the line with a little bit of saline, small amount, and you can notice there's a little bit of turbulence, and that will let you indicate whether you are seeing the tip or actually you are not seeing the tip. It's almost similar when you try to, the turbulence is the same way that you see when you're doing the bubble test for if you're trying to looking for if there is ASD or not. That's all. Thanks very much.
Yeah. So we did for this baby as well, and actually I've not put the slide here, but yes, it did demonstrate that tip was at that place.
Oh, thanks.
And over to you, Solis.
Thanks, Anay. It was very interesting and fascinating, and it's good. One thing I would say, the PICC line you used, did it have the steel wire inside?
Yes, it was a Premicat 1 French which had a guide wiring.
Right. Can I share my experience in these situations?
Please, yeah.
Because just experience in comes after. You, I think, correctly determined the position of the tip of the PICC line. I wouldn't challenge that. But even if the right position, you can still actually have a complication. So it doesn't rule out completely. So, beating yourself that, that POCUS was more or less the, let's say, not sufficient method of confirmation probably is not correct, or a little bit self-harming, if anything. Yeah. Now, regarding these situations, I've given about maybe 4 cases when we had the PICC line going up into the neck. I did, in 2 cases, I showed my registrars how to deal with that in a very simple way without taking anything. Keeping the sterile field is the first thing. Second is you actually pull the line out into the position that you feel is actually in the more or less subclavian artery. Then you pull out the wire, and because you have a venous flow advancing slowly without the introducer, the catheter will go into the SVC without a problem. And I'm sure that in 2 cases we tried that. Both cases we ended up having the tip going into SVC. The important thing is to keep the field clear, and you know, to keep the procedure after the X-ray that's done also clear. And the repeated X-ray you actually need to do, but you won't be able to see in X-ray the tip if you do that, you know, not ultrasound but X-ray. Then either you can actually use the contrast or inject the constant at the time of the X-ray. And sometimes that's the only bloody line that you can actually put a PICC line. And in situations like that, it is vital because, you know, if you're going to need to take this out, you are without the central axis. And that helps quite a bit in situations like that. Thanks.
Yeah, so I think just in response to that, so the line that when we saw that it didn't have a guide wire in, our practice is to remove guide wire as soon as you're in, and we do an X-ray without a guide wire. And yes, I think that mechanism we've used many times with 2 French line, which has much bit more tensile strength to it. Second thing is about the governance side of it. I think all of us have fortune or misfortune of being in a court of law. I think the question here is, I'm not being defensive, but in the court they will ask what's the best practice that is recommended by your body in the country. And if you look at lots of UBCs or line-related complications which are in coroner's court, the referral, it's always been referred to the best practice guideline, which is what I shared earlier on, which there is a lot of emphasis on use of X-ray for that. So I was just putting a kind of a governance side to it because you know, it's not. We all know that the ultrasound is much more sensitive. You see structures in a more 3-dimensional way than what you see in X-ray. But going back to again, if this ends up in court, the current national document which advise and what we should do suggests X-rays as a modality. So that was, I just put it there just to discuss that aspect as well. But absolutely, I mean, the necklines, when they go, especially 2 French, they flip. Sometimes you can give a small bolus and pull it back and advance and it go in the right direction. Here, this line was 1 French and the guide wire was already removed. And actually, as we pulled that out, it looked to be in a big lumen vessel, so we left it there.
No, thank you, Anay, for the comments. And Anay, we have got more hands there. But before I go to the next one, is there any evidence where, or you have looked in your experience that 1 French lines has more tendency to extravasate over the 2 French because for any reasons?
No, so those 472 guidelines that we reviewed as a part of audit, I've not put all the outcomes from there. There was no difference seen in the size or caliber of. I think the only factor that was seen to be associated with complication was malposition lines. So lines which were short just on the shoulder or just in the groin, which were still accepted as and used, they were associated with complications.
Thank you. Over to you, Augusta, Anay. If you can turn your camera on.
I'm at work, so the camera might not work, but if you can hear me.
No worries. We can hear you very well. You don't have to turn your camera. We just thought we'll introduce yourself because we've not met you before.
My name is Augusta. I work in the neonatal unit in University Hospital, Wishaw, Scotland. Thank you so much for that lovely presentation. I just had a few comments and I wondered if, and also wanted to hear what other people's experiences are. I think you touched on that, moderator, when you asked about, is there something to say about the kind of lines we're using now? Because it appears to me that we are having more instances where we now know that some of these morbidities are contributed to by extravasation of fluid, TPN, into different cavities. Now, is it because we're interrogating them further, that's why we're picking them up? Or is there any other confounding factors? Because it's one thing for us to focus on the line positioning and the POCUS and all of that, but is there anything else that might be contributing to this? And I think you just kind of touched on that when you asked the presenter about his experience about those lines. That's the first thing. And then the second thing, run about the case you presented, when you talked about the line being in the right position, and I totally agree with you, it looks like it was in the right position and all of that. I wonder, in your experience, have you found a contributory factor to be the line advancing and retracting repeatedly? Because in my mind, that volume of fluid you had, if that volume of fluid in that cavity was accumulated over a short period, I would have thought that baby would have deteriorated really, really faster and even more significantly. Do you think there's a contributory factor to lines, either because the positioning is not adequate or whatever, advancing and retracting, contributing to these extravasations we are seeing into these cavities? And I wonder what other people's experiences are in these two areas.
Anay, do you get the question?
Yes. So I think coming back to your question, are we seeing it more? So I just presented our data. So we've had 2 babies in our unit over the last 14 years for over 30,000 line days. So I don't think we're seeing more. Obviously, we are looking after much more vulnerable preterm population. It was almost unheard to have a laparotomy in a baby at 450, 500 grams, which we're doing now not uncommonly. So I think that probably represents the population we're looking after.
Absolutely.
As far as the line adjustment is concerned, for this baby, there wasn't pushing or pulling. There was just withdrawal of the line, and we just left the tip. So I don't think there was a lot of line handling or adjustment as such.
Oh no, I didn't mean with regards to you during the procedure, but for lines that have been put in and have been certified as being in the right positioning, subsequently some of these patients come up to have had extravasations within them, even though on POCUS and on X-ray it looks like they're in the right position. I'm wondering, do you have any experience or data to show that there are a group of patients where there's migration and retraction of the line out with clinical indication as a contributory factor is my question.
Yeah, I think at least in my unit, we have not had experienced increased long line related complications. Obviously, CLABSI rates is a problem, which is the case for most of the surgical centers. But as such, line complications, we have not seen a surge or increased numbers.
Does that answer your question, Augusta?
Yes, it does. Thank you very much.
Yeah, but I think so. Longer you stay in this specialty, and as we look after, as Anay rightly mentioned, is because you're asking to the whole forum. And if you have worked as a consultant for 10 years, I'm sure you would see at least 1 or 2, which goes with what Anay is saying about 13,000 catheter days. I had one case where looking after a congenital diaphragmatic hernia baby who was after post-repair, had a line, again inserted on the right brachiocephalic, was extubated, was getting better, sudden deterioration, and had a pericardial effusion. And the line was still known to be in the right place. So as you know, Anay mentioned, there are more, I think so, pathophysiology of complications, just not the puncture of the vessels. It could be through lymphatic retrograde flows and other stuffs there. So again, we didn't see that the line had migrated, but baby had a massive pericardial effusion, unfortunately died, had postmortem, and went to coroner's court. And I'm sure all my colleagues over here would have stories of their own. So sometimes, the malposition is the biggest risk, but unfortunately, we have a group of baby where we see line complication despite of the steps being in central lines. And I've got a case series for myself for UVC, where UVC was absolutely fine, and they are much more vulnerable, but then we noted extravasation there. Does anybody has their own stories to share, any particular thing, or shall I move to the next one?
Well, I think just to come in, I agree with you what you say, because I've been here for I think 14 years now, and
yeah,
the first time we've had that was in 2017, and it was exactly what you just described. The line was in the right place, but there was still some extravasation. So I think you're absolutely right, and thank you for that.
Yeah, no, I think so. It's important for us not to beat ourselves, because as a neonatal consultant and neonatal people, we are very sometimes harsh on ourselves. But to know that this babies are very, very vulnerable. The risks of esophageal perforation just through a benign NGT insertion, line extravasations, though in right places, are known complications. So as a neonatal world, we should be aware, though you always try and get them at the best optimal position as you can. Now, over to you, Ahmed. I'm sorry to keep you waiting. And if you can, if possible, you can turn your camera and do a quick introduction so that we know you.
Yeah, sure. Can you see me now?
Yes, yes.
Yes, perfect. I'm Ahmed. I'm one of the neonatal trainee in Manchester. Thank you for sharing this very interesting case and showing us where to look at the line tip position. I have one comment because you highlighted about guidance on PAPM framework, and I think it's very important to have a governance support to the POCUS practice, which is now evolving, and many units adopted using POCUS as a standard of care. I'm one of the group who are looking at now at reviewing and updating PAPM framework on CVC, and I think there are a lot of discussions going on to include recommendations on lung ultrasound during line insertion and when reviewing tip position. Some colleagues from anesthesia, surgical team, and neonatal and radiology are looking at the best evidence. So I hope that will be some update which will support the POCUS practice. And I have a question. You demonstrated that the tip is still in a good position even after developing pleural effusion because of TPN leak. And then what would be the best technique? Is it taking the line out and considering putting a line from the lower limb? Or do you think it's still safe to put another line from the upper limb in the SVC because the mechanism that you have shown is there is a possibility of erosion of the endothelium because of hyperosmolarity?
Yeah, I mean, I think as we talked about, different mechanisms here, I don't see a reason why you can't put a line still centralized. So for this case, we put a line in within 24 hours of extravasation. We put it on the left side, and it was left in non-net vein, and it was absolutely fine. I think the likely process here was there was a micro erosion of the subendothelial or endothelial area leading to PN leak. We didn't go on the same limb, but we went on the other side. But I don't see pathophysiologically reason to not go in head and neck vessels.
Okay. Thank you.
Thank you. Solis, your hand is again. Do you have any comments?
Yes, I just Ahmed, exactly. Sorry, I'll put it on. I missed my introduction. I'm neonatal consultant in Aberdeen. I think Ahmed mentioned the good point of the review of BAPA guidelines and to have the governance behind the use of the POCUS. And I think new group or in BMPA would be probably one of the first tasks to do that. So I wish everybody, including myself, all the best in that joint work for review and to put the focus on the governance documents that will at some stage take the additional questions, especially in medical legal cases.
Yeah, so I think Mohammed may be able to talk about that, but yes, NeoFOCUS Special Interest Group, I think that would be one of the tasks to get the frameworks and guidelines in to inform clinicians.
No, thank you so much, Solis. Marika? Over to you, Marika.
Hello, can you hear me?
We can hear you. If you can do a small
Perfect.
introduction for yourself, Marika.
I'm a neonatal trainee. I'm at the moment working in NTS, and I worked before in Georgia. So hello, Anay.
Hi.
Thank you for presentation. I have a quick question. You mentioned about the erosion to endothelium and using the guide wires. What about if people use a microsite for these babies? You obviously are inserting the wire. Would this increase the risk of damage to endothelium?
I think the short answer, Marika, is don't know, because the microsite is something which has come in last 18 months to 2 years. And obviously you wouldn't use microsite for one French line. You would be using it for 2 French line, which will tell you that this baby is will be anatomically a bit bigger and a bit more robust. We've not audited, but we haven't seen anything with microsite related problems. I don't know, everyone in the team on the call have used microsite. So it's like a guide where you put a 24 gauge cannula, you put the microsite through it, remove the cannula, and then thread over 22 gauge catheter over it, and then you can put 2 French lines through it.
And we had a amazing experience. Means I don't remember the name, but I would have shown you the X-ray. There was a difficult long line. So one of our newly joined consultant who was, so we always give them because they're the best in the job in terms of putting line. And this baby, it's a tiny baby. So, but she got it through the to use microsite to get the line in, and the line was, you could see the line tip from the skin. So it's went. You can see that's going all the way through the common iliac vein, and somehow it went up to one of the branch vein. And just so the problem with this microsite, I feel, means my experience at that stage was it's good to get in to a place, but then later on it can move to bizarre places. Yeah, so that was our experience. So probably we were not lucky with our experience.
Yeah, I mean, again, the other thing with aim of microsite is not to thread in quite deep in. So you just want to get a few centimeters in the body for you to be able to thread over the catheter. So I doubt anyone would put microsite that it will go into the central.
I don't think so. You can put it that in. Probably it was unfortunate because microsite has got a very limited length. So it's used like a cildering.
If you have a kilo baby or 1.2 kilos, you can go quite centrally.
Yeah, it is still a cildering technique we use microsite as.
Yeah, I think it has its role. It's fantastic in a bigger babies, babies with hypoglycemia who need 20% dextrose, 15%.
Absolutely. And this is what it is, probably a replication of what they do in PICCU in adult, right? Yeah. So it's like a application of cildering technique in preterm babies, actually. Does anybody has any other questions? We are just on time. Marika had this historical hand. So Anay, and if I can ask the group, we have a team from various parts of the country. Does anybody not do X-ray for their line insertion? Have they replaced POCUS with X-rays?
I mean,
are we there yet?
No.
Answer is no. That's what I was thinking. So, Anay, have you changed your practices then?
Following what, this event?
Yeah.
No. I think obviously you need to work very closely with pediatric radiology team, which actually we are in a way blessed by having a fantastic proactive team. So essentially, the difficult lines where you're outside neonatal POCUS spectrum, I do show them from governance and learning point of view, which actually is quite helpful exercise. So following this event, I sat down with one of the pediatric radiologists who agreed that on the ultrasound, the line looked to be optimal. So the short answer is no, but again, working together, this is a learning process for everyone. But
absolutely agree.
Working with pediatric radiologists.
And do you guys have any surveillance? Because we are now, and I'm sure a lot of other colleagues from other parts, because of the medical implications and any catheter-induced injuries now, if there is a mortality and the baby related, so then it goes through a coroner's inquest process. It's compulsory. So and a lot of units have started some surveillance. Do you guys have any surveillance for your central lines for UAC, UVC, or long lines? And I know you mentioned that it doesn't decrease the incidence of complications. Do you think it is appropriate?
I think short answer is no, just in terms of resource planning, because this POCUS is a operator dependent investigation, and we didn't want to set something that we wouldn't be able to fulfill. So at the moment on the unit, we have 3 consultants who can POCUS as well as some trainees. Hence, putting something as a policy or SOP, it's challenging because you need adequate trained workforce to be able to meet that. What we have definitely changed is we've moved away from accepting the suboptimal central UVC, which is slightly lower down, which is accepted as which used to be accepted, that we moved away from. So that, but that's the only thing that I can see. Obviously, any line where there is unusual course, we confirm the position by ultrasound, but there isn't any surveillance program as such.
No, thank you so much, Anay. Augusta?
Sorry, in response to your question about what people do across board, I wondered, is the aim to totally discontinue the use of X-ray for ascertaining line positioning, or to use them in unison, i.e. with POCUS leading? Because I think what Anay just said about capacity and capability for point-of-care ultrasound scan in various units that might be using these accesses. So what maybe the BAPAM folk will be able to answer this. What is the aim and for moving forward for doing these things? And are we at the point where we can actually say the point-of-care ultrasound scan should be the only, you know what I mean? So I don't know if that question is
No, this is a very
pertinent
and an important question. And we, being a part of NeoFOCUS group, and I'm sure our chair, Mahmood, would have something to say on it, but we are working on it to come up with the best practice for central line insertion. We the problem is in PICU and adult setting, there is lots of literature published, and people are replacing X-rays, and they think the POCUS itself can be enough. I don't think so. In newborns, we are there yet. And again, it comes back to Anay's point of perspective. And my perspective, that I think so it's better the whole team does the same thing rather than I doing one thing and somebody else doing another thing. So it will take some time, I think, so where we get to a place where we can say confidently that okay, we are okay with central lines, because we know that there are some caveats, and even with POCUS, where it's easy to misidentify the lines when you cannot see the tip, and sometimes when you don't see the tip, because again, when you're using ultrasound waves, using a curvilinear probe, you might not be able to see the tip very well, because the ultrasound waves has to come back and be collected by your probe. And though you don't see the tip, you sometimes, when you X-ray it, you see that it's lying in the heart. And this is one of the problems. And again, it's user dependent, and you are taking real-time decisions. So these are, again, I think so, more challenging. Central lines POCUS, I think so, are the most challenging in terms of POCUS use. Mahmood, do you have any comments on it, actually? So that would be nice to hear from you.
Thanks, Bikash, and thanks, Anay, for this excellent case, and literature review was really very thorough and very good. I think all these questions are very valid, and I think we are at the start of our journey. I know some units are ahead of the game already, like St. George's, but what we are aspiring in our group with the collaboration from our colleagues as well in the larger neonatal community, we would like really to put some guidelines in place, framework of practice with the standardized views and recommendations, how we're going to move things forward from that perspective. Just the short answer for that question, are we going to replace X-rays with POCUS? I don't think we're going to do that in the near future. This is a learning curve, as you said, Bikash. We need to upskill, all the workforce to be able to do that first of all. And when we reach that stage, maybe because our cohort of babies are different from other adults, maybe adults are confident enough, and I know in anesthesia part of their curriculum and training they do the POCUS, but we're not there yet. So maybe we just take one step at a time and move forward, hopefully.
Thank you. Anay, sorry, I didn't see your hand earlier.
Sorry, just one comment. I think there is one step before we reach to a point where we stop all the X-rays. I think the first step would be to reduce the X-ray exposure. I mean, in our long line data that I presented, some babies had 6 X-rays, 7 X-rays to define the line position. So I think first step would be to try and just have 1 X-ray as a baseline, and subsequent adjustment would be guided by ultrasound. Even if you do that, we demonstrated in our cohort that your radiation burden goes down significantly. Plus, in our cohort, we identified 8 babies where actually the lines were in arterial tree, where actually on the X-ray it was felt to be in the optimally placed position. I think we get away with most of them. One of the babies actually had ischemia to the toes, so they're not trivial. So I think my aim personally would be to try and reduce the radiation exposure to these babies to define the long line position.
No, thank you so much, everyone. Thank you, Anay, for taking time to share the case and share all the learnings and doing such an extensive, well-researched presentation for all of us. And thank you, everyone, for attending our weekly teaching. I hope you all had learning from here. And in summary, we know that it is a challenging, central lines are challenging, determining their final positions are challenging. One of the, most of the complications from central lines happens because of malposition. Having said that, you can still have complications in central line even when the tip is in optimal position. So, and watch the space from NeoFOCUS BAPM SIG, where we are working on the case to develop framework and best practices. It might be not all evidence, because we might not have evidence for everything, but best practices to develop how to maintain a septic field while doing POCUS, what views are needed, what training curriculum is needed, and which would be which you can then use in your unit practices. And thank you so much, everyone. Thank you, Anay, again.
Thanks, everyone.
Thank you all.
And I know as a ritual, Mahmood will load the recording on the group for you guys to have a look.
Yeah, we'll upload it to YouTube later this afternoon.
Thank you. Thank you so much.
Thanks. Bye.
Thanks, everyone. Bye-bye.